But my name is Neelam Khurana, and I am a general pediatrician at Healing Hearts Pediatrics, and I did the EAC back in 2016. And saying my internet connection is stable, so I'm unstable, so I'm going to move so that it doesn't mess things up. So, and I definitely learned a lot from that. And really today, we're talking about screeners, and the majority of the time is going to be on the MChat, which most of you guys know. So it's not going to be very, oh yeah, if you guys can mute yourselves. There we go. I'm muting those who aren't muted, sorry. But it's good to know that you guys are there because it's totally silent from this end. So anyways, we're gonna go through the MChat as well as some other screeners. So
it's on now, yeah. So
hello, I'm gonna mute you guys. So the learning objectives for today are learning the benefits of the screening tools and identifying the early signs of autism, understanding the benefits and the downfalls of level 1 screeners, and the MChat is one of those. And then gaining confidence in administering the MChat with the follow-up questions and identifying the next steps, which some people have had experience with and some people have not. And then recognizing which patients will benefit from further assessments. So some of these slides are a little bit, lots of information, but you don't necessarily need to know all of this. I'm going to review it with you guys real quick, but the main benefit of universal screening. So we do screening in lots of different areas so that we can get all the information that we need in a short period of time when patients are in the office with us. Obviously, to get early diagnosis, the early detection will reduce the burden of disease. Of note, the current rate of autism in the general population is 1% to 2%, but there's an increased rate in premature children. That's one of the articles that I actually had attached to this, as well as low birth weight and extended NICU stays. And they've shown the severity of the autism in the premature children, or at least the percentage of children that are premature with autism actually increases by how long they're in the NICU, as well as their birth weight, whether they're premature or not. And then early intervention, obviously, we know can reduce the severity. We know that 90% of the brain development happens in the first 5 years of life. And so we know that if we diagnose early and treat early, we can retrain those pathways and get these kiddos help and reduce the severity of the symptoms for them. The current recommendations by the AAP in the Bright Futures is doing the autism screening for kids at their 18 to 24-month well visit. If there was a 30-month well visit, we would do it then, but they're not approved for us yet. And then universal screening is supported by many different organizations: American Academy of Pediatrics, Neurology, Child Neurological Society, the positive impacts of screening tools, better understanding the child's presentation at an earlier point so that we can tailor their needs specifically for them, including early intervention with AZIP, getting them better school placements by starting with an IEP at 3, and then getting them additional therapies to increase their communication skills, assist with cognitive function, more so communication of cognitive function, motor skills, interpersonal skills, decreasing problem behaviors in the future, and then, of course, decreasing the long-term economic burden and establishing more working members of society. And this slide I thought was really interesting. It shows that basically about 63.8% of parents first had a concern at the child's age of 3, but only 18.5% of them actually had a diagnosis. And 32.3% of them, so half of them, were receiving a service, any service, so even AZIP. So half the other kids at 3 hadn't even received any service. So, and overall, the statistics show that fewer than 1 in 5 children with autism have been diagnosed before they're 3. And that just reduces the amount of time they have for their brain development and resolution of many of their symptoms. I'm throwing this in there. It is part of one of the articles, and there are negative impacts to screening tools. And they're important for us to remember. Additional financial burden. So if the child doesn't have autism and we're sending them off to get evaluations done, then that's an issue for them, for the family, for the insurance company, for the healthcare system in general, for the state. And then, of course, we have these false positives, and then we have to refer them to clinicians, which are limited in number. So that decreases the availability of clinicians for the patients who need to get seen, and increased emotional burden on the clinician and the family with false positives. And there are organizations that don't recommend it, the American Academy of Family Practice and the UK National Screening Committee. So moving on, the meat of this talk is about the screeners. There's sort of three areas of screeners. One is a level 1 screener, which is the MCHAT, which we all use. And another one is a CSBS, the DPITP, so it's a toddler version. There may have been some of you that had done that SARC study where they were actually distributing that to the little ones at 12 months and up. So that was considered one of the level 1s. MCHAT is the standard of care right now. Level 2s are, okay, the level 1 shows that there's a concern. So now we need to figure out what that level of concern is and how serious that concern is, because the level 1 screeners aren't as specific or sensitive as a level 2 screener. So STAT is one of them. We've been trained to do that, and that's one of the things you guys may be learning to use for children less than 4, which is a great tool, but it takes a bit of time. The RITA is another one that's actually will not take that much time, 18 to 36 months, and can be done in less than 10 minutes in the office. So it's kind of a nice one. And then the SORF is like a video one where you have to have all these things set up. So it's not feasible for a medical practice. And then broadband screeners, ASQ, you guys talked about last time. And they do have, and I'm sure Gross told you, but there's definitely kiddos that'll have delays in personal, social, and communication, which can be signs that you would look at to make sure that you're asking families further about autism. The PEDS tool, CSBS, not as helpful in getting us to the next steps. So in the level 1 screeners, the majority of the stock is going to be on the MCHAT revised version with the follow-up. So it's designed to identify children who are at risk for atypical development, but the positive predictive value is not that great for autism, basically about 50%, but it's very high for any developmental disorder. So majority of those kids, 98% of those kids will have something, but it's not that specific for autism. It requires a 6th grade or higher reading level for parents, so something important to consider. And then it's usually done between 16 and 30 months. And there are multiple languages, there are many versions. The latest and the greatest that we use is the MCHAT F, which is the follow-up. The important thing to note on this slide is that it has a low positive predictive value, and it is lower in younger toddlers. So it does improve as you get a little bit older. But the follow-up questionnaire really does help the most. And it improves the positive predictive value, but does not improve the sensitivity. And we're going to go over the follow-up questions to show you how this can be done in the office setting. Some of the articles recommend that you do a follow-up for every single question. Well, that's not really feasible to do in an office setting. It's a 20-question format, and the 2, 5, and 12 indicate a fail if they're answered as yes, and then sometimes it's going to be considered a fail. And then the other numbers are considered a fail if they're answered as no, and then sometimes it's also going to be considered a no, because those are going to be the ones that you want to go back to and ask the follow-up questions. You add up the number of fails, and this is just a quick, you're not expected to actually read this side, but this is what the MCHAT looks like. You add up the number of fails. 0 to 2 is considered low risk and no follow-up is necessary. Keep in mind that there's still going to be some kids that have just 2 abnormalities, but they are significant abnormalities. My child gets overwhelmed by noise, and my child makes funny movements around their face. Majority of the time, those things are going to be false positives when you go back and ask, because parents think playing peekaboo and doing little games are considered odd movements. Or if a child is startled by a loud noise, then they say they respond to noise. So the majority of the time, those things are going to be false positives. But there are some kiddos. I had a kiddo last week where it was clear this child is flapping and this child is scared of any noise and goes and hides in the room. Those are the only 2 positives that the mom had on there. So technically no follow-up is necessary, and they're considered a low risk, but those high key answers, I would say follow back up on, whether they're false or whether they're true positives or false positives. I would just follow up on those particular ones. And then the 3 to 6 fails. is considered medium risk and definitely want to have a follow-up for all those questions. And then they suggest at 7, and it says 7 to 23, but it's actually 7 to 20. That's the old score for the previous MChat. But the 7 and above, they say you can just automatically refer them. So we're just going to go through the majority of the questions one by one and go over the follow-up questionnaire. And I have my group chat thing open, so if you guys have questions, I'll keep an eye on that and try and pop up and answer them as they come up. And then all these are available for you guys on the slides, and I believe also the follow-up questionnaire packet is available in the documents that were given to you, and if not, it's all on mchat.org because it's hard to really see some of these things on the slide. So number one, if you point at something across the room, does your child look? And if the answer is no, then that's considered a fail. But your follow-up question is going to be more, does he look? Really just verifying. Does he really not look? Is he looking at the object? Is he pointing at the object? Is he saying something? Is he looking in the direction? Or is he totally ignoring you, looking around the room, looking at his fingers, not really having a clue of what you're talking about? So, and I've added these flow sheets in there because they are, a little bit more detailed than what we're talking about overall. There are some areas, but it gives you an idea. Obviously, if the answer was no, then you can do the follow-up questions, and then they fail again if they ignore you, or they look around randomly, or they look at your finger or their fingers. And there's some that are pretty straightforward. So that's a pretty straightforward one. Have you ever wondered if your child might be deaf? So this one, if they answer yes, that's considered a fail. Usually this one requires follow-up questions. So do they totally ignore you? Do they not hear sounds? Do they have they been tested for their hearing? All those other things. They've found that actually hearing loss is not really something that you can say, okay, if the child has hearing loss, well, they don't have autism. It actually may increase your risk for autism because you're not able to take all the input that the environment is offering you to learn and build those neurological pathways. So, but also if the child is zoning out into their own world versus is the child ignoring you because they're busy playing a game. Again, some of these kids who are on the spectrum are so into their game that they cannot be pulled out. So you're going to want to ask more specifics about this to really get an idea as to whether or not that child truly is unable to hear versus in his own world. So ignoring other people, ignoring the sounds. And then of course you want to get the hearing tested. But again, if the hearing is tested and is abnormal, that does not exclude autism. And so I just wanted to go through some of the next few slides, just talking about the behaviors that have nothing to do with hearing that are associated with autism. So poor eye contact, even if somebody has hearing loss, they'll still look at you. Echolalia, when they're repeating the speech, which is a very typical thing that we see in autism, where you're having a conversation and a child hears what you're saying and says a word that's part of your conversation for no purpose. So they would just randomly say conversation. Obviously, if that child has hearing loss, but they're able to repeat something that you've said out of context, that is not affecting their ability to exhibit whether or not they have autism. Delayed acquisition of language can be from hearing loss, but can also be from lack of comprehension. Delayed